Good evening to everyone present here with us today. This is Sriyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Sania Hasnan. Ma'am is MBBS MD at Hospital Administration, Technical Product Manager at Solalso. With the help of Ma'am and her wonderful insight, we will be taking a close look on today's topic, which is robotic surgery in current trends and recent advancement. Now, without any further delay, I would like to welcome Ma'am at our forum and would to like to hand over the session to her. Over to you, Ma'am.
Thanks, Shriyon, and good evening, everybody. Thank you for taking time out to join today's session. We'll be talking. I'll be taking you through, some recent trends and advancements that we've seen in robotic surgery. We'll start with a brief history of, robotic surgery and how that has evolved over the years, and we'll take a quick look at how this is different from laparoscopic surgery and the pros and cons of delving in this area. Um, okay, right. So let's understand what robotic surgery is. Robotic surgery, also known as robot assisted surgery, refers to a minimally invasive surgical technique where specialized robotic systems are employed to assist surgeons in performing procedures. Now, when a procedure is called robotic, it does not indicate that a robot is really doing the work. Instead, it refers to surgical procedure in which doctors use robots to guide their actions. One or more robotic arms may be used in robotic surgical systems, which doctors can operate remotely and accurately from a console nearby. Let's take a look at the brief history of how robotic surgery has evolved over the last years. Now, did you know that advancements in laparoscopic procedures in the 1980s were at first received with criticism, but today represents a big leap in decreasing the invasiveness of surgery? Clinical benefits include smaller incisions, which obviously would reduce trauma, reduce the risk of surgical site infections, and of course, the hospitalization time. Starting with the first laparoscopic cholecystectomy surgery, laparoscopies have become an integral part of most specialties today. Forward to a few years later, first robotic assisted surgery came in, and almost a decade later, an FDA approved the first Da Vinci system, a robot assisted surgical arm. Now, this is an interesting landmark. A lot of you may be aware of it. The first transatlantic telesurgery, called the Lindenberg operation, was carried out in 2001. The surgeon was located in New York City in the US and remotely controlled robots to laparoscopically remove the gallbladder from a 68-year-old woman in Strasbourg in France. This was the world's first transoceanic operation on humans that has been conducted over high speed fiber optic connections. The researchers used the Zeus robotic system from the US and a fiber optic communication system owned by France. The operation lasted less than an hour and involved data transfer of over 14,000 kilometer circuit. Then we come across first microsurgical vascular anastomosis, first cohort of breast reduction surgery, mastectomy, the Musa system being used, robotic scope, Simani system, and so on. So these have been some developments over the years. Let's try to compare what a traditional surgery is with as compared to a robotic assisted surgery. Traditional intervention surgeries now here needs to be conducted in the operating room. The surgeon manipulates the catheter with one hand and the guide wire with the other. The delivery, the withdrawal and twisting of the catheter and the guide wire are all involved when passing through the different blood vessels during the operation. Now, in case of a robot assisted surgery, this can be conducted outside of the operating room as well. The surgeon can be protected from radiation while operating the catheter and guide wire, and can be present remotely using a robot's controller. So that's one way of seeing how robotic surgeries are performed. Let's look at a typical setup of a robotic surgery. So, a typical OR room, what that would look like, what would be the components of a robotic surgery, what's the kind of team that is in place, the kind of equipment, etc., is something that I would like to take you through in brief. Now, what's important is all surgical staff should be trained in robotic surgery that are operating using any of these tools, and must have basic knowledge in which must be gained by proper training. The team should be persistent and dedicated for robotic surgery cases to achieve a good learning curve. Surgeon and assistants must not only be having mastered skills in operating one type of robot arm, but also have basic knowledge of robotic surgery system and should be aware of troubleshooting the system. Surgical assistants also play a vital role and should be efficient enough in trocar placement, draping, docking, irrigation retraction, and so on. A conventional operating room can be used, but it's best to have a robotic surgery system set up in a dedicated RS room. This is a typical scenario of setting up a robotic surgery. You've got the robotic arm, the surgeon's console, and a vision cart. Let's take a look at what these are. Now, the basic system for robotic surgery consists of, like I said, a vision cart, a patient side cart, and a surgeon side cart. A robotic surgery system includes a camera and a mechanical arm with surgical instruments attached to it. The surgeon controls the arm while seated at a control center called the console, or the surgeon side cart, as we've written here. The surgeon sees a magnified, high definition 3D view of the surgical site. The robotic surgical instruments are specially designed to replicate the human range of motion while filtering out any tremors or unwanted movements. So the patient side cart is the arm that is, mimicking the movement that the surgeon does, and the vision cart would give you a detailed vision of the surgical field. Here are some examples of other equipment instruments that are used. For example, they're similar to laparoscopic instruments here. So just to give you a brief comparison between what gets used. Versus needle, you see the hook cautery, the suction irrigation setup. In this case, you've got the robotic system, you've got a camera, you've got a trocar, drapes, and so on. Now, one thing that's very important here in case of robotic surgery is the positioning of the patient, the cart, and the vision cart. In contrast to conventional laparoscopic surgeries, extreme positioning is required in order to achieve optimized exposure for robotic surgery, and often requires a strong teamwork to ensure patient safety. The vision cart should be obviously next to the patient in order to visualize the component displayed and also to prevent uninterrupted and free movement. Patient cart for standard systems has camera and instrument arm. Each arm has several joints and clutches for gross movement. One dedicated to free gross movement and the other to adjust final trajectory of arm for final docking. That's how a robotic system would work. Now, I quickly take you through some steps of docking, how this works. Abdominal access and port placements are very crucial, obviously, to start a robotic surgery. Pneumoperitoneum can be created using either open or closed technique. Position of various ports could vary from patient to patient, according to the procedures, and would also depend on the surgeon's preference. In order to have optimum working conditions, the following principles should be used. That is, the camera port should be in same line as a surgical target area. Target area should not be more than 20 centimeter. Working port should be at least 8. As this is an example, these specifications are an example of the use of a Da Vinci system. With different newer systems, you would have some variations in these. Now, looking at the console function and a quick look at some of these terminologies, just to make you all aware, surgeons should be aware of console different parts, and terminologies. For example, there's a clutch plate, a camera paddle, a focus bar, and a cautery paddle. The left side of the console bears typically, a stop angle button, console height adjustment. The right will have, an emergency stop button, and so on. It's important when you start using, like I mentioned, training becomes very important for the surgeon and the surgical team. Each robotic arm that gets used is different from the other, so it's very important that you refer to the manual of these, and have a strong team who can troubleshoot when needed. Moving on to benefits of robotic surgery, one of the main benefits of this is improved patient outcome. Now, precision becomes very valuable here. It enables surgeons to perform intricate and delicate maneuvers with accuracy that surpasses what the human hand alone can achieve. Enhanced dexterity, for instance, robotic arms can rotate 360 degrees. And mimic the natural movement of a surgeon's hand, but with significantly reduced tremors. Three-dimensional visualization, for instance, robotic systems provide high-quality 3D visualization of surgical field, offering a depth perception and spatial awareness that surpasses the traditional 2D laparoscopy. Another area would be reduced surgeon fatigue. Unlike traditional open surgeries, which often requires prolonged standing and holding heavy instruments, robotic surgery allows surgeons to operate comfortably from a seated position at the surgical console. This reduction in physical fatigue enables surgeons to maintain peak performance throughout the lengthy procedure. There, none of these come without risks. So let's take a look at what would be the top few risks or disadvantages of a system like this. Human error, for example, along with mechanical failure. Mechanical failure are often rare, but can definitely happen in a case of a robotic system. The components like a robotic arm, the lens, the camera, and instruments can completely halt the procedure if they go awry. Extreme body positions can cause nerve palsies. That's especially if this is done in inexperienced hand. Bulkiness of a robotic system setup may that can be overcome by being in a large institution, having dedicated robotics arm surgery room available. Complications that would require your surgeon to switch to an open procedure can also happen. For instance, system, rarely, but in case of a system failure, moving to an open procedure could be something that some cases would see. Now, let's take a look at robotic surgery versus laparoscopic surgery. We'll come across some similarities and some differences between the. I have chosen not to compare this with traditional. There are obvious, comparable points between those two. But let's see how different is this from laparoscopy. In case of precision, we see higher precision due to robotic arm, which has greater dexterity and range of movement. In case of laparoscopy, it's completely dependent on the movement of the surgeon. There is limited dexterity as compared to a robotic arm, which has a 360-degree movement, reduces tremors, and so on. Visualization is better. You have 3D visualization here versus a 2D. Ergonomics, improved ergonomics, surgeon operates from a console. In case of laparoscopy, surgeon may experience fatigue, awkward position, etc. Incisions are similar. Learning curves steeper due to complexity, and the kind of technology, or a lot of this is still relatively new. Laparoscopy is widely used. The learning curve is much lower. Cost, because this technology is new, there's a very high initial cost of setting up. Generally these surgeries are more expensive. In years to come, the cost will go down, just like any technology. That's typically the cost curve for any new technology. Complications, I would say, more or less similar, but there's slightly lower risk of certain complications as documented in literature, but I think we need more data to be able to compare this. Um, Surgeon skill dependency, less dependent on surgeon's manual skill. Obviously, in case of laparoscopy, the surgeon's doing everything. We will discuss the surgeon skill dependency a little more in detail in the coming slides. Training requirements, obviously high. Technology integration is possible, which is limited with laparoscopy. Now we'll delve into how robotic surgery and AI can work together to improve, surgical outcomes in this session as well. With respect to accessibility, of course, laparoscopy is widely used. This is relatively new. It's available in limited setups. Range of motion, again, enhanced, limited in case of laparoscopy. Tactile feedback, like this is again something important, and I'll discuss this when we're talking about AI, is limited. You don't, which is obviously much better in case of laparoscopy. Surgeon fatigue is lower, they obviously will be higher, and application, this is growing range. We're still learning to apply this across different specialities. Laparoscopy has a very broad range of application. Now let's take a look at robotic surgery and artificial intelligence. Now, artificial intelligence, as we all know, is revolutionizing nearly every aspect of healthcare and can be particularly impactful in robotic surgery. Let's take a look at how the application of AI can lead to intraoperative enhancement. AI modeling allows surgeons to have advanced intraoperative metrics. For example, force and tactile measurements, which today lacks in a robotic surgery, but AI can enhance that. Enhanced detection of positive surgical margins and allowing for complete automation of certain steps in surgical procedures. Intraoperative enhancements provided by AI can be in two category: robotic autonomy and surgical assessment and feedback. How much of work can the robot do, and how much of surgical feedback is the robot giving to the surgeon. So in case of artificial learning, you'll have, it'll take into account patient characteristics. It'll have, it'll already have literature available. It'll have robotic sensors and will be able to help assist the surgeon during the surgery. Now, I was talking about autonomy. The International Organization Standard, as we know, the ISO defines autonomy as an ability to perform intended tasks based on current state and sensing without human intervention. However, please note that autonomy is not a singular state, but a scale in which the degree of human intervention is traded against full independence. So, to give you an example, we've I've taken this from a literature which explains 5 different levels of autonomy. That is traditional, where there's no automation, to complete, where there, something that is level 5, complete automation. In case of level 0, human performs all surgical skills, including that includes open laparoscopy, and also the master slave robotic surgical methods. For example, the Da Vinci is also a master slave robotic surgical arm. Then comes level 1, where there is some assistance available. The intraoperative image guidance, for instance, augmented reality rendering. Human surgeon performs all surgical tasks in this case as well, but has some support to have better, visibility, etc., in the surgical field. Then we move to level 2, which is partial automation, that is reduced required level of human input. But again, the surgeon still performs majority of the tasks. Now, level 3 would be conditional automation. Automated bone drilling, for example, is being used to pre-specified depth with human setup. Robo can perform certain procedural steps without human intervention. Moving to high level of automation, automated skin closure or lymph node dissection. The robot is capable of performing most, if not all, parts of complex procedures with minimal human input. And the last level 5 would be surgical robot could perform, giving an example, could perform hypothetically a urgent cholecystectomy during a space flight, for instance. Robot is making all the surgical decisions with no human input. like I said, some of these are in theory, but this is to explain the level of automation that can exist. Delving more into how autonomous systems are available. So example of robotic surgical device of variable autonomy that exists today are, like, for instance, the Da Vinci is a master slave robot completely dependent on human control. Then we have the T Solution one, which is an orthopedic robot, and the Maser X. Now these two offer reduced level of human input for a limited range of surgical tasks. I'll take you through another example of I think you will find this interesting. So we're comparing a vehicle and how autonomous vehicles exist today with how automation of surgery, and this has been taken from a literature by Topol. The concept is based upon different levels, again, like I said, 0 to 5 of autonomy based on technology. So 0 encompasses the traditional and historical practice of surgery as it existed today. A human surgeon performs everything. Level 1, intraoperative image guidance, may be performed in real time, intraoperative fluoroscopy or stereotactic navigation, but human obviously still performs all aspects of the surgical intervention. Moving to level 2, robotics combined with image guidance may assist in surgical procedures. For example, I said the T Solution and the Maser X robots. These permit a reduced level of human input by automating critical components of the procedure, such as guiding trajectories of the instrument, and this helps reduce errors. Moving to level 3, the device is capable of both navigating and performing limited surgery. The real life analogy of this automation is the CyberKnife stereotactic oncology robot, which plans and conducts surgery autonomously. As it uses external radiation beam, it is not strictly surgical and its clinical versatility is limited. So as we move further in the level of automation, most of these things are more in theory than in practice today. Let's look at level 4, for example. The robot is capable of performing a wide range of surgical procedures, largely unaided. Humans may be required for most complex portions of the procedure, an assistant, and for supervision and assistance should the robot require. And the last level would be full automation. Robot does complete a procedure unaided. Now, what's the impact AI can have on robotic surgery? How do we move away from the master slave? How do we make the system more intelligent so that's able to provide surgeons with an overall better outcome in their surgery? So, current robotic robots are controlled by a master slave dynamic. Like I said, the surgeon does all the tasks. However, recent advances in AI and machine learning, they seek to expand the capability of surgical robots and augment the surgical experience in the operating room. The surgical robots rely on data captured through sensors and images to operate, and this plethora of data capture is the key driver behind AI innovation in robotics. Now, surgical field enhancement, for example, intraoperative visual environments are constantly changing, as we can see, as dissection or repair tasks progress, which can lead to marked changes in intraoperative image quality. Now, to combat these changes, and these are all documented literature, published articles that I have pulled to bring this information to you. So, Ali et al., for example, they have developed an online processing framework capable of denoising, deblurring, and color correcting real-time camera imaging to enhance intraoperative visualization in knee arthroscopy. Very interesting. So, the moment you improve the visibility for a surgeon, obviously, you have, lesser chances of error, better outcome in surgery. The method outperformed existing image enhancement with significantly reduced computation time to image display. Another impact of AI in robotic surgery, how this enhances the quality, is native tissue recognition. Now, surgery often involves identifying surgical planes, which are anatomical points at which tissues meet that are free of critical structures such as arteries, large veins, or nerves, and are therefore safe for dissection. Kumansu et al. Have developed a deep learning model using surgical video from robotic assisted gastrectomy capable of automatically segmenting loose connective tissue fibers to define a safe dissection plane. Expert surgeons gave the model a mean sensitivity of 3.52 out of 4, indicating a good model performance for safe plane identification. Another example on how AI can improve a surgical field is comprised of two elements, that is your native tissue, which we just saw in the previous slide, all your anatomical structures, etc., and a non-native device. These are your surgical instruments, your clips, sutures, and so on. One of the greatest challenges in the implementation of AI in surgery is distinguishing between these two. Accurate delineation is critically important for the development of augmented reality, that is surgical field image with computer generated overlay and surgical field enhancement. D. Backer et al. Presented a model consisting of deep learning networks to delineate instrument during robotic assisted kidney transplant, which achieved a die score of 97.10%. This is a marked improvement from the current standard in AR guided robotic surgery with minimal disruption of 3D overlays. Now, we spoke about tactile feedback. You remember when we were comparing robotic surgery with laparoscopic robotic surgery typically lacks any tactile feedback. Now, open procedures allow surgeons to palpate anatomical structures or feel changes in tissue resistance during dissection and suturing tasks, something that has not yet been developed for robotic surgery. Doria et al., for example, sought to apply haptic feedback to the palpation of anatomical structures. They first developed stiffness models to characterize the mechanical properties of intrauterine leiomyomas. They then adapted the stiffness model to deliver haptic feedback through a wearable fabric haptic device, such as a greater vibration indicated stiffer tissue. Force is also generated intraoperatively when retracting tissues, and excessive force can lead to preventable adverse events such as tissue tears and hemorrhage. Here's another example. So Zhu et al. Developed a robot for transoral surgery that uses piezoelectric sensors embedded in the instrument tips to detect force on tissue up to 15 N. Another interesting advantage of having AI into robotic surgery would be to focus using AI to offload some of the physical and mental workload intraoperatively by automation of surgical tasks. Eslamine developed a model that incorporates intraoperative tool tracking robotic kinematics data and intraoperative image data capable of autonomously translating the camera view and determining the correct zoom for surgical visualization. The suturing on the surgical robot is also seeing steps towards automation. Marcus et al. Presented a method that automates the key looping step required to suture an anastomosis during neonatal tracheoesophageal fistula repair. Just to now, before I wind up, take you through robotics that are being used worldwide. So we've got the Da Vinci system, which has been available for a few decades now. The Mako system, Rosa, Cyberknife is there. These are the different companies. For example, Medtronic has a Maser X, Hugo RAS system. Where are these being used? So, of course, Da Vinci being one of the oldest has a wider application: prostatectomy, hysterectomy, cardiac valve repair, knee replacement, hip replacement are being used, surgery for tumor, spinal surgery, bronchoscopy, general surgery, and eye surgery, and so on. These have been some of the applications that have come over the past few years. These are some of the reference literature that some of them are a comparative analysis, some of them are meta-analysis, and I've specifically picked up articles that are meta-analysis done and articles that have done a Prisma, use a Prisma protocol to bring forward this to the audience today. Happy to take any questions now.
Thank you so much, ma'am, for your wonderful presentation. So, ma'am, we do have some question if you like to take that up.
Sure.
Yeah. So, ma'am, the first question is, how do you address concern about the potential for technical failure or errors during robotic surgeries?
Right, that's a good question, and that's definitely something that we would worry about. Technical failure of a robotic system, number one, is something that is rare. It's something like, I'd be scared of driving if I knew that the technical errors of a car can fail very often, right? If cars fail very often, we would probably all stop driving. But we know technical failure in cars are low. Similarly, the kind of the research and the technology that goes behind building these robotic systems ensures that failures are extremely rare. That's number one, so you would have it rarely. Now let's look at the rare scenario. While they are rare, when this does happen, what is it that the surgical teams can do? And that's why I mentioned, right, one, it's important that the team is skilled in troubleshooting, when there are minor technical glitches, etc. If the system fails, then the team needs to be prepared to be able to move to an open procedure or switch your procedure, and do a manual, a complete manual, or surgery. So yes, that these are certain things that one will have to keep in mind. I think with time, as technology improves, the rare technical breakdown would be even rarer. Yeah.
Thank you, ma'am. The next question is, what areas of surgeries do you think will see the most growth in robotic assistant procedure?
So from all the literature that I was going through, what I have been seeing there's a lot of application in oncology. In the removal of tumors, especially with the help of AI, to be able to delineate between a cancerous tissue and a non-cancerous one. I also came see a lot of usage in orthopedic surgeries and spinal surgeries. I think these are some of the areas that robotic surgery has a significant impact already. I'm also seeing that in cardiac surgery. I think with time, all of this would increase, but these are the areas that sees a large, a broad application.
So, ma'am, there's one last question. Are there any specific robotic system or tools that you believe will shape the future of surgery?
I wouldn't pick a name as such. I've been reading up about, you can check that out as well. So there is the CMR Surgical, that's a company based in the UK. We have Medtronic, which is worldwide, and we have the Da Vinci, which is, has been around and has multiple new models. I think what will shape the future of robotic surgery is the capability of using AI. Right, there are certain disadvantages of this surgery. Like I said, you don't have any tactile feedback. There, if you're able to enhance the visibility, of the surgical field, you're able to delineate between tissues, which a robot cannot do. I think if any arm or surgical arm or company is able to make the most of AI, and data, I think they are the ones who are going to actually change, the future of robotic surgery. And it'll be really nice for doctors to, keep themselves abreast with the latest technology. I bring these topics because I'm keen that doctors understand, they know about, new technology that's going around, and of course you can take a conscious decision whether to, use it or not.
Thank you so much, ma'am. That's all from our audience, and thank you so much for answering all our questions. So, before concluding, ma'am, any last remark from you?
No, thank you so much for joining in. Do let me know if you have a topic in mind. I typically like to speak on topics that bring awareness around new technology, especially with respect to AI, in healthcare across different areas. The intention will always be to ensure that doctors are abreast with, the latest in the field. As a doctor, when I was younger and practicing, I was not aware of all of this, and I that's my reason to keep picking topics around technology and AI.
Thank you so much, ma'am, for joining us today. With your permission, I would like to conclude today's session. Thank you.
Thank you. Thanks a lot.